Amy Gibson from the Patient-Centered Primary Care Collaborative. Thanks so much for joining us today. You've joined our webinar that is an activity of the Center for Accountable Care here at the PCPCC entitled Managing High-Risk Patients in Accountable Care Organizations. We have a great speaker lined up for today, so thanks for all of you who are able to join. For those of you who are not able to join, you can let your colleagues know that we will have this webinar archived up on our website by the end of the day tomorrow. So it will be available for viewing at your convenience, or if there's anything that you missed, you'd be able to go back and check in on it. So I do want to extend a great thanks to our co-chairs for the Center for Accountable Care. Our co-chairs are Craig Samet, Ted Epperly, Dana Safran, and Blair Child. And want to thank them too for their work in getting Dr. Bolt to do this presentation for us today. For those of you who are new to the PCPCC, thanks so much for joining us today, and we hope that you will be participating with us on future webinars and calls. I do like to remind everyone that we have our spring stakeholder conference registration open now. If you go to the PCPCC.net website, you can register for that conference today. That'll be here in Washington, D.C., April 23rd and 24th. It's our first two-day conference, so we're really excited. We're expecting some great participation and attendance, and we have some amazing speakers lined up for that. So you can get our entire agenda downloaded if you go to that registration link through our website. So again, I'm encouraging everyone to register earlier than later this year because we're expecting a lot of participants since we're going to be in a bigger venue. We'll have better space and better capacity for everyone to participate. Hear some amazing presenters from all over the country and experts in the field of medical home, but some also incredible networking opportunities. And I think those are held as very an opportunity that people look forward to when they come to our conferences. It's really the opportunity to get to know what people are doing around the country, get to talk one-on-one with those, and to find out who are some of the partners that they can engage with around their transformation to patient-centered medical homes. So if you haven't been on one of our webinars before, the way we do things is we'll hear from Dr. Bolt. He'll give his presentation. And then afterwards, we'd like to hold all of the questions until the end of the presentation. We do only accept the questions in the box through the webinar function. So if you look on your screen in your dashboard or your control panel, you'll see a little box that you can enter in questions. So feel free at any point during the presentation to go ahead and type your question in, and then I will be giving those over to Dr. Bolt at the end of the presentation, and we'll have him respond at that time. If we do run out of time for questions, we'll save them up for Dr. Bolt and post them up to the website. So feel free at any point to go ahead and put your question in. I mentioned it before, I'll remind you again, the webinar in its entirety will be archived up on our website. If you go, you'll see it right up on the front page, a link to download that webinar and to take a look at that again, or again, share it with your colleagues. We really try at the PCPCC to disseminate this information and share these best practices, but mostly through our partners in that. So I'm going to introduce Dr. Bolt and then turn the presentation over to him. So thanks again, Dr. Bolt, for joining us today. Dr. Bolt is a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health. He also holds joint appointments on the faculties of the Johns Hopkins University Schools of Medicine and Nursing. He is a teacher, a researcher, and a board-certified physician in family medicine and geriatrics. Dr. Bolt has extensive experience in developing, testing, evaluating, and diffusing new models of healthcare for older persons with chronic conditions, most recently the guided care model. He's published 2 books and more than 80 articles in biomedical scientific journals. From 2000 to 2005, he edited the Models and Systems of Geriatric Care section of the Journal of the American Geriatric Society, has reviewed manuscripts for 20 scientific journals, and served as a grant reviewer on study sections of the NIH and AHRQ. During 2009 to 2010, Dr. Bolt served as Health and Aging Policy Fellow at the Centers for Medicare and Medicaid Services. During 2010 to 2011, he served as a senior advisor in CMS's Innovation Center. Welcome again, Dr. Bolt, and I'll turn the floor over to you.
Thank you so much, Amy, and thanks to the PCPCC, and thanks to each of you who has tuned in today. I hope this will be a helpful session. What I'm going to address is how patient-centered medical homes, one way that they can effectively manage high-risk patients, that is, those patients who have multiple chronic conditions in the context of an accountable care organization. I'll start with some brief background information about what is the problem that's designed to address, and set a bit of context because this is not the only model that has been tested recently in the last few years. I'll then focus on the guided care model, describing how it's organized, how it operates, and show you some results from a recently completed randomized trial of this approach. I'll finish up with some information about technical assistance that's available now to help other organizations that want to adopt this model or some version of it. And then we'll have a time at the end for some questions and answers. So let's get started. As you all know, chronic care, that is care for these people with multiple problems, is often fragmented, hard to access, inefficient, unsafe, and very expensive. As you see in this pie chart, which represents the total Medicare spending for the most recent year, 2010, it shows that in this pie, the total pie represents about $500 billion. So this is real money. And the large red wedge represents the percent of that spending that's on people with 5 or more chronic conditions. And the gray wedge over toward 3 o'clock shows the spending on people with 4 chronic conditions. And added together, we see that a quarter of all seniors, that is Medicare beneficiaries, have 4 or more chronic conditions, and yet they account for more than 80% of healthcare spending. So it's a huge investment in a minority of the Medicare beneficiaries. So why is that? What's wrong with chronic care today? And many of you know this already, so I'll go fairly briefly. But basically, there are at least these 8 flaws. There's no proactive monitoring of conditions. We wait until people get sick and come in for care, missing many opportunities to intervene early. We have limited access to primary care providers for urgent visits. People often have to wait too long, and so they end up going to the ED instead. When they do get into primary care, their visits are often hurried and limited to just one problem per visit or so, and rarely can the primary care provider get into the complexity that these people really face. There's poor coordination among providers, and that means between primary care and specialty care, between either of those types and hospitals and rehab and nursing homes. We just don't talk to each other very effectively. There's particularly, that's a problem in transitions. We have terrible discontinuity, and as we all know, there's a great emphasis these days on improving transitions when people leave the hospital, trying to reduce the amount of 30-day readmissions. Unfortunately, our system provides very limited guidance for self-management. We're over-medicalized, and patients sense that, and they don't really take the reins and manage their own illness in ways that they could, and we'll talk about that in a few minutes. We often don't ask people what they want, and we don't know their preferences, and so particularly in these very complex patients near the end of life, we give them care they don't even want, because our default is to do everything. And finally, we provide very meager, if any, support for family caregivers, and these people are essential to the care of people with complex healthcare needs. So that's just that's the gloom and doom part, to see that, well, that we addressed all of these, I hope, in this model that we developed, but it's not the only model. And I wanted to just set the context by mentioning some other types of newer models that have been designed to care for people with chronic illness. The first category is community-based care coordination teams. The emphasis there is on community-based. In other words, the special coordination resources such as nurses, social workers, pharmacists, community health workers, and so on, they're not based in primary care. They're based in a community organization. And examples of these are the Community Care Program of North Carolina and Vermont's Blueprint for Health program. The second major category is special clinics for complex patients or patients with complex needs. And these clinics were popularized about a year ago in an article in the New Yorker by Atul Gawande, and he talked about the Camden Coalition for Healthcare Providers, the hotspotters, talked about the intensive outpatient care program that Boeing has been running, and the Commonwealth Care Alliance in Massachusetts. These are clinics that are designed specifically for complex patients, so they're a bit different from typical primary care in that regard. The third category, and the one we're going to talk about today, is primary care-based coordination teams. That is, the extra resources needed to manage these complex patients are located and integrated into the primary care practice or the medical home. Examples are the GRACE program that was developed and tested in Indianapolis, and then the guided care program that was developed here at Johns Hopkins, and which I'm going to spend the rest of the time talking about. So what is it? What is guided care? In concept, it's very simple and easy to understand. It's just the placement of a specially trained registered nurse into a primary physician's office. And that nurse, located there in the office, collaborates with usually 3 to 4 physicians in caring for 50 to 60 high-risk patients with chronic conditions and complex healthcare needs. One difference between this model and many others that you may have heard about is that the nurse partners with these patients, these complex patients, for the rest of their lives. In other words, there's no discharge from the guided care program. It's not time limited. Their chronic diseases are not going to go away. So the nurse stays with them for the rest of their lives. Now let's get down into to the weeds here a bit about looking at specifically what are the activities of a guided care nurse in working with the physician and caring for these complex patients. There are 8 primary activities, and I'll go down the bullets here to show you. The first is an assessment. This is a comprehensive assessment that the nurse does at the patient's home, assessing all of the usual biomedical features, as well as the patient's preferences for care, their nutritional needs, their family caregivers, their home safety, all the things that we think might be relevant to the care of a person with complex needs. This is a very structured 10-page outline that the nurse follows in gathering this information. The nurse then enters that information into an information technology system that has embedded in it evidence-based guidelines for managing the most common chronic conditions that affect older people. The system then generates an evidence-based plan of care, or we call it a care guide. This is an overall guide to the patient's care in all of their chronic conditions. It includes sections on their medicines, their diet, their physical activity, their self-monitoring activities, follow-up, prevention, and so on. Once that's been generated, the nurse and the physician then sit down together and they go over it, because each of them now knows the patients from a slightly different perspective, and they modify the plan because evidence-based guidelines don't fit every patient exactly. Once they're happy with it, the nurse takes the plan out to the family and the patient again and says, well, this is what we've come up with. What do you think to the patient? Are you willing to buy in? Is this a good plan that you want to take on? Patients can change it as well, and so because the main idea here is to have the patient feel ownership of this plan, have the patient engaged in their own care. So once that's all agreed upon, then the nurse converts it for the patient into something called an action plan, which is really very similar to the care guide or the original plan, except that it's written in patient-friendly language, lay language, big font, graphic symbols, designed to be readable by someone with a 6th grade education. And it serves as a reminder list. It's put usually in a plastic jacket with a magnet on the refrigerator or a cupboard at home, someplace the patient and family members will see it frequently. It serves as a reminder of when to take the medicines and what they're for and what to eat and not eat, and what kind of physical activity is recommended, and so on. All the things that the patient can do to manage their own health. So once that's all set up, the nurse then begins to monitor the patient proactively. So every month, at least, sometimes more often, there will be a phone call or a visit in which the nurse will talk to the patient, and they'll use the action plan as a kind of a template for their conversation. So they'll go over it. What medicines are you taking? Any problems? Do you need refills? How's the diet going? How's the physical? How's the walking? How's the what are your last 5 blood pressure readings and your blood sugar readings, and so on? And it's a way of reinforcing the patient's self-management activities. Also at that time, the nurse sometimes detects new problems that have come up and allows them to make an early intervention. The nurse also carries a cell phone that the patients and families have on their speed dials, so that if there is a problem that comes up, even in between these monthly conversations, they can reach the nurse immediately, and the nurse has good access to the physician because the nurse is right down the hall from the physician. So there's very good access to getting quick response to emerging problems, which is so important with these patients particularly. As you can see, the nurse has been supporting patient self-management in a number of ways. And an additional way is that she makes referrals to self-management classes if they're available in the local area, and in many areas these are becoming more and more available. A very high priority for the nurse is to smooth transitions between sites of care. So when a patient is going into the hospital, the nurse makes sure by one way or another that the hospital staff has a copy of the care guide or the care plan, which is a beautiful short summary of everything they would need to know about this person's health condition and plans for management. Then when the patient is about to go home, the nurse helps in the discharge planning and then makes a home visit and visits the patient and family in their own home to make sure that the medicines are reconciled. That is, medicines that the hospital recommended are reconciled with the medicines in the medicine cabinet that the primary and other specialists were prescribing before the admission, to eliminate the confusion that so often results in readmissions. The nurse also makes sure that the patient and family are familiar with any new equipment that they've just acquired in the hospital or need to get from a pharmacy.
Sounds like we lost Dr. Bolt there for a minute. Let me see if we can get him back on the line.
Oh, dear. I'm still here. Can you hear me?
Yeah, you're here. You're fine. Continue, please. Thanks. Sorry.
Okay. I was talking about transitions of care and the nurse making this home visit after the discharge from the hospital. And then the nurse also makes sure that the primary care doctor has been briefed on the admission, what was done, and make sure that the patient has an appointment and a ride to come back and see the primary care doctor in a timely fashion. To a lesser extent, the nurse also coordinates in the same way with all providers, making sure that wherever the patient goes, the patient brings the care guide and the action plan and shows it to hospitals, emergency, specialty clinics, rehab facilities, and so on. You see the list wherever they go. Again, trying to encourage all the providers to work together. Another important role is educating and supporting the family caregivers. Back at that initial home visit, the nurse also assessed family caregivers. Usually there's one primary family caregiver, and the nurse does a structured assessment of that person, determining what they need, what they know, and provides them with information about their loved one's illness, about ways to manage that illness, about resources in the community, which is the last bullet here. There are many community services that can be helpful, and yet many people don't know about them or know how to access them. So the nurse has a database and knows what the patient and the family needs and connects these people with such resources as Meals on Wheels, adult daycare centers, special transportation systems, Alzheimer's Association, and so on and so on. So that's a brief summary of the 8 primary activities of a guided care nurse. So as you can see, it's quite a lot to do with 50 or 60 patients that are always changing, it seems. So to test whether this model achieves its initial goals, we've just finished a 3-year randomized trial of this guided care model, in which a little over 900 high-risk older patients were enrolled. They were established patients already of 49 community-based primary care physicians who were practicing in 14 teams. Each team was 3 or 4 doctors. And so the typical setup was there would be a practice that would have 2 teams in it, and our statistician randomly allocated one of those 2 teams in each practice to get the guided care nurse to work with 3 or 4 physicians and their high-risk patients. And then the other 3 or 4 physicians in the practice and their high-risk patients served as the control or comparison group. So these are called clusters that were randomly allocated. Then once the system was in place, we measured several outcomes from both insurance claims and also from patient surveys, as well as family surveys, doctor surveys, and nurse surveys, looking at quality of care, health and function, satisfaction with care by all the people involved, as well as, very important, utilization of emergency departments, hospitals, and skilled nursing facilities. And by the way, in all these slides where you see a reference down in the right corner, that's where the information on the slide has already been published. So to identify patients that were eligible for this care, we used something called a predictive model. We used Medicare's HCC model, which scans the past 12 months of insurance claims, identifying what chronic diseases were placed on those claims, and then converting those into a score, which is basically a risk rating. It quantifies how much risk the person has of being a high utilizer in the year to come. So note that it's not based on last year's utilization of services. It's based on chronic diseases that people have. And so in this study, all the Medicare beneficiaries in a practice were screened using this HCC software. And then those with the 25% highest risk, in other words, highest HCC scores, were declared eligible to be in the study. And here's a slide showing what those participants looked like. They were in their late 80s, about half black and half white, half male and half female, half with high school education and half without. About a third lived alone, and from a list of 12 chronic conditions, they had an average of 4.3. Their average HCC score was 2.02, which is just a little over 2, meaning these people had twice the average risk of being a high utilizer in the year to come. And about a quarter of them had functional disability. So the next series of slides, each slide shows one outcome, and the reference at the bottom of the slide shows where this has been published if you'd like to read more about it. At 18 months, we surveyed the patients using something called the Patient Assessment of Chronic Illness Care. It's a validated survey instrument to ask people to rate not their satisfaction, but the quality of the care they've received. And what was apparent was that guided care recipients after that first 18 months were more than twice as likely to rate their chronic care in the highest category than were those in the control group. This is the numeric version of what I just said. In other words, in aggregate, the total score, there was an adjusted odds ratio of 2.1, which means, as I said, they were twice as likely to rate their care in the highest category. This slide shows physician satisfaction, or actually change in physician satisfaction between the baseline, that is before the study started, and when we surveyed them anonymously a year later. The blue bars represent the change in the guided care physicians, or the ones that had worked with these nurses. And the orange bars represent the change scores for the physicians down the hall who did not work with the guided care nurses. You see the blue bars all are in the upward direction, and a couple of them are statistically significant, meaning that the guided care physician satisfaction in all these dimensions shown at the bottom were all improved. The orange bars all went down except for one, meaning that the usual care physician satisfaction was actually lower a year later. One can speculate as to why that was. Perhaps envy at their colleagues down the hall who had this wonderful nurse working with them. The nurses were quite happy with their work. We surveyed them anonymously as well, and they gave high satisfaction ratings to all of these 7 characteristics of their position, saying things like, "Best job I ever had." I love getting involved and with the patient, the family in depth, and staying with them over time, and love the partnership with the physicians, and so on. Now, this is a very interesting slide. This is the utilization of several resources in the system. What I'm showing you here is not from the whole study. This is the subgroup of all the patients. It's about 40% of the total patients in the study, about half in the control group and half got guided care. But these are all the ones that were in managed care program, Kaiser Permanente of Mid-Atlantic. So it's quite striking that the blue bars represent the amount of difference between the utilization by the control patients and the guided care patients, showing that in guided care patients, there's a 15% fewer hospital admissions and 49% fewer hospital readmissions after 30 days, 21% fewer hospital days, 47% fewer SNF admissions, 52% fewer SNF days, and 17% fewer emergency department visits. So quite striking. Only 2 of these are statistically significant, both having to do with skilled nursing facilities. But this was not found in the other the patients who received their care in non-integrated practices. So there's something particularly successful about this model in systems that are already fairly well integrated, like having a common medical record, electronic record, and having employed physicians and multidisciplinary team in their culture. Just to acknowledge the funders of this study, AHRQ, National Institute on Aging, and the John A. Hartford Foundation and the Langeloth Foundation. So in order to help organizations that would perhaps want to adopt this model or some version of it, the team here at Hopkins has put together 4 forms of technical assistance. And there's a lot more information available at the website shown at the bottom of this slide. But and I'll tell you a little bit more about each of these. But to give an overview, first of all, there's an implementation manual whose name is shown here. And this is a very practical, step-by-step manual for practices to implement the model. Second, there's an online course for registered nurses to prepare them to be guided care nurses. And until June, there's scholarships available to pay the tuition for them to take this online course. Scholarships are made available by the John A. Hartford Foundation. There's also an online course for physicians and other practice leaders to acquaint them with some of the principles that they need to be aware of in order to make this model work. And finally, an orientation booklet for patients and families. As I said, if you want to get details on any of these, just go to the guidedcare.org website that's shown at the bottom here. Now, quickly, I'm going to give you a little more information about each of these. This is the implementation manual. It's a small book. Describes how this model operates and helps practice leaders determine, first of all, if it's right for them. Helps them to prepare for implementing this model. Provides them very practical tools for implementing the model, as well as finding, hiring, and managing guided care nurses. And it even includes a checklist for integrating the nurses into the practice. This is the online course for nursing. It's 40 hours. It's a combination of asynchronous and synchronous, meaning most of the time the nurses spend just online with a computer, but once a week they have a live session, a webinar like this one, with a nursing instructor. And at the end there's an online examination. This course is offered by the Institute for Johns Hopkins Nursing, and if a person successfully completes the course and the test at the end, they get a credential, a certificate in guided care nursing from the American Nurses Credentialing Center. This is refers to the online course for physicians and practice leaders. This one's shorter and less expensive, 9 modules, 9 hours, totally asynchronous, meaning it's just the learner and the computer. There's no live portion to this course, so they can take it anytime they want or any part of it that they want. This provides an awareness of the competencies that they will need in order to bring this model into their practices. Typical topics are how to lead change, communicate with patients, participate on interdisciplinary teams, care management, continuity, HIT, and so on. And this course also provides CME credits up to 9 hours. And this is the final piece of technical assistance that we've made available. It's another booklet for patients and families. It describes in a narrative, kind of a very easy, readable format, how guided care can help patients and families and what they can expect from it. And there are hard copy and electronic versions in English and Spanish so far. So let's get out of the weeds a bit now and just step back and look at this whole model in the context of an accountable care organization. This represents an investment strategy because it's not free to have an additional provider, this nurse, doing these activities, none of which are billable under most insurance plans, requires an investment. And so the way that the business model that could be used by an ACO would be to, for the ACO to invest and provide a subsidy for primary care so that they could afford to have this nurse in the practice. And then the dividend or payback for the ACO would be, of course, savings in utilization, such as I showed for the Kaiser system. And also, a little less tangible is loyalty, loyalty of patients and families to the ACO, as well as reduced turnover rates because of greater satisfaction by physicians and nurses. And now, let's just stop and think about the infrastructure needed to have a team like a guided care team in an ACO, in a patient-centered medical home within an ACO. These are lessons that we learned by doing this study, and we want to share with you. And we can, this is just about the last slide, so we'll be able to go into questions on any of these or anything else in a few minutes. But just to reiterate, what we've learned is the very large importance of accurate targeting. That means selecting the right patients for this intervention. This is not for everyone. It's too expensive. We'd like to give it to everyone, but can't. But we need to identify patients whose complexity really needs this kind of an approach and who can benefit from it. So there are a couple of general ways to do this. In our study that I mentioned, we only use the predictive modeling approach. That's not probably practical in the real world. It may be part of the solution, but we need to have the clinician's judgment involved in there as well, so that the predictive model might be used initially to very efficiently identify some people for possible inclusion, but then perhaps the clinician, the primary care provider who knows the patient well, could modify that list provided by the predictive model based on what the clinician knows. A second major infrastructure asset would be interoperative HIT. So having primary care, specialty care, and hospitals all in the same computer system would be marvelous, and that's what we experienced actually in the Kaiser system. The nurses found it enormously helpful in their ability to coordinate care and transitions for these complex patients. The third bullet here refers to management of the targeting and management of the coordination, and this is sometimes overlooked. But these are complex, ongoing processes. So let's just talk about targeting for a moment. Targeting doesn't happen just once. It doesn't just happen once a year. These patients change all the time. So a person who was not a high-risk person perhaps suffers a heart attack and then a stroke. They suddenly become a high-risk person, and so their system must be designed to detect on an ongoing basis new people who've newly become complex and at high risk. That whole system, whether it's based on predictive modeling, clinical judgment, or a combination of the two, needs to be carefully set up and carefully managed so the information flows in a timely way and can institute appropriate action. Similarly, management for the coordination process, in other words, management of the guided care nurse and the physician team, is very important. Remember that there were 8 activities that the nurses do, and all the nurses, of course, can come from different backgrounds. They have things they're particularly good at and things that maybe they're a little rusty on, and we all have our tendencies to gravitate toward things that we're most comfortable with. And so sometimes you'll find that nurses or other providers will tend to gravitate toward just doing some of the activities and not so much emphasis on others. That's sometimes not helpful because they may be ignoring or downplaying some of the more important activities, such as transitional care. So it requires that you have a system for managing, in other words, monitoring the performance of the nurses in working with the physicians and the patients and providing feedback to them so that they know, and basically a quality improvement program for the nurses to make sure that they're continuing to stay focused on the elements that have been shown to be the most effective in producing the goals that we're all trying to achieve. And finally, financial rewards or incentives for desired outcomes would be a highly desirable feature, although we didn't do it in our study. But we found that if the physicians see the nurse as a valuable asset that's going to help them to achieve what they're trying to achieve, and even perhaps increase the amount of their bonus at the end of the year, they're going to be much more inclined to develop really tight, effective working relationships with the nurses. And that's so important to have that effective, smooth teamwork between them. So in a case where the physician does not have any particular incentive other than just, say, professionalism, the physician may more or less tolerate the nurse working alongside him or her on these complex patients, but not really integrate so much. But if the physician sees the nurse as a valued partner who can help the physician to achieve either better quality that results in a higher pay, better satisfaction, patient satisfaction, or some sort of a financial incentive related to reduction in utilization, these are all motivators for helping the physician and the nurse to work smoothly together as a real partnership. So that's the end of my prepared remarks, and I'll throw it open now to questions. I think maybe Amy has some questions.
I do. We have quite a few questions that have come in. Well, thanks so much, Dr. Bolt. That was a great presentation, and I can't tell you how relieved I was to find out that the audio just cut out on my end and not yours. So my apologies for that, but you did a much better job at your presentation than I would have. So that's good news for all of us.
No problem. Yeah, these things happen.
Yeah. So I've got several questions, and some of them you were able to already answer for those who are participating. But just to maybe elaborate a little bit more on the training that's available, is there continuing education units available for the nurses who complete the training?
Yes.
And for the physicians as well, or?
Yes. Different, of course,
Great.
but yeah.
Right. Okay. So the model that you tested with your program was specifically with RNs. Have you done any investigation or thoughts about different types of licensure in the type of professional, maybe a licensed social worker, or some practices are exploring the use of community health workers to play this type of role? What are your thoughts about that?
Right. Well, obviously, we only tested RNs, so but I can tell you that we debated long and hard all the issues you mentioned, plus others, such as how about advanced practice nurses and so on. And it was an interdisciplinary team that developed this model after doing a lot of literature review and talking to many people involved in this kind of care. And we came up with the conclusion that the nature of the tasks, those 8 tasks, although some of them could be done by non-nurses, if some of them really wouldn't work very well, such as if you had a community health worker, meaning by that, a person who's basically not a health professional, but maybe taken a short course and is of the community, they have great value, and I think we really underutilize them. And they could be involved in helping the nurse, but they're certainly not equipped to be helping with medication reconciliation on a patient who's just come home from the hospital, or teaching people how to use sophisticated medical equipment, or even talking with the physician about trying to develop a comprehensive care plan for people with multiple chronic illnesses. It's just over the head, and we thought about it even the LPN or LVN level, and thought it was probably too intensive for even someone at that level. That's why we came up with the idea of the RN level within nursing. Now people say, well, what about a social worker? We've debated that long and hard as well. Social workers clearly can do many of the tasks, but again, these ones that require medical sophistication and respect from physicians in primary care, specialty care, in hospitals, EDs, and so on, we thought probably it would be better to have a nurse and equip the nurse with some social worker type skills like community resource use and so on, than to try to do it the other way. So I think other models could be tested, and they will be tested, but that's what was our rationale for why we tested the nurse model.
Great. How about looking at other types of populations to implement this model? We got a couple questions asking about the utility of this in pediatric populations specifically.
Yeah, I think the common element here is complexity of healthcare need. And so I wouldn't really base it on age, although in our study, we studied people who were age 65 and over because that's where the highest concentration of multiple chronic illness is. But there are certainly people with complex healthcare needs at younger ages. Think about there are children, as your questioner mentions. There's people with HIV/AIDS and their complications. There's people with chronic renal failure that are kind of middle-aged people. But lots of categories, cancer, so on, where the model would probably need to be adapted a bit. But the principles, all those tasks, the things that need to be done are true regardless of the age of the patient. So I would say, I guess in a short answer would be, I think the model is relevant and it would have to be tweaked a bit.
Excellent. So as it relates to the various activities, you described the nurse coordinators having a lot of flexibility to meet the needs of patients, whether through telephonic or even home visits. There were some questions about the home visitation piece. Did the nurse coordinators, did they do a lot of home visits, and how did this work out in their schedule? It seems that there have been some participants on the call who've struggled with that. They found that it just becomes too overwhelming with their other responsibilities.
Yes, good point, and true. The guided care nurses typically they always made an initial visit to do the home assessment. The second visit was usually when the person was coming home from the hospital. If people didn't go in the hospital, and they typically didn't get another home visit. A lot of the monthly monitoring calls and so on were done just telephonically. So you can't, as your questioner raises, home visits take time, and they can't be out visiting 50 or 60 patients frequently. So we had just certain mandatory minimums like initial assessment and post-hospitalization. And we also left it open to the nurses to use their discretion. There were situations when the nurses made home visits because there was something their clinical judgment was that they were not able to assess the person adequately, and that it would be better for them to go visit the patient than the patient to come into the office. But it was clinical judgment on the part of the nurses, and they didn't make too many of those.
Excellent. There's a lot of questions, as you can imagine, around the financing of this. And certainly you addressed that in talking about accountable care organizations, and I think there are a lot of models that are soon to be tested, and now certainly we're getting a lot of interest, certainly from private payers. We've talked a lot about here at the PCPCC and on many of our calls that they're certainly seeing this as a good investment to make in primary care. But through your particular study, were you able to find, or did you do any data collection that showed any cost savings to the primary care practice, or was there always the increased expense related to implementation of this program?
Yeah, unfortunately, it is a cost to the primary care practice. There really is no cost reduction there, and really no increased revenue either. So in order for this to be economically viable, there has to be a transfer or an investment strategy where either the ACO funds the nurse, or if it were in a non-ACO environment, the insurer would fund it, because the entity that benefits financially from this model is the entity that's paying for hospitalizations and ED visits and so on, because that's where the benefit occurs, but that doesn't really help the finances of the primary care practice. So there really has to be a business model that includes a transfer of funds to the primary care practice so that it can afford to have the nurse.
So knowing that you did have external funding for this particular program, were the practices who were involved in it able to financially sustain this as part of their primary care practice, or did it go away when the grant went away?
Well, interestingly, we had 7 nurses, and 6 of them continued in their roles, but they weren't being paid by the primary care practice. When the grant funding ended, the 2 insurance companies picked up the costs in the model that I was suggesting, where they paid the cost of the nurses. So Kaiser Permanente continued their 3 nurses. It's just part of their regular way of doing business. And the TRICARE, which is Medicare-like insurance for retired military personnel, that program picked up the cost of 3 other nurses. The one nurse that we had to let go was one that was in a 100% fee-for-service practice, and Medicare was not able to pay.
Yeah, that's certainly always a struggle, especially if for practices who are in communities where they don't have payers who are jumping on board, or have the support from other programs to help finance this. But
right.
for those who are maybe on the call that are payers and are willing to partner with a practice, what's the overall cost? What's the investment? Is it equal to about the average salary of a registered nurse in that community?
Yeah, it's quite variable across the country. In our area, in the Mid-Atlantic, Baltimore area, the average cost was about $96,000, and that's salary, benefits, transportation for the home visits and the hospital visits, communication equipment, services, supplies, that sort of thing. All the costs of having a nurse we tallied, and it was about average $96,000. Now, I know there are parts of the country where nurses' salaries are higher, and there are parts where nurses' salaries are lower. So I don't want to say that that's the number. People in each region would know what it would cost them. But the only thing that we required was 3 years of clinical experience after nursing school, and so you can sort of figure what's the average salary of a nurse with that degree of experience.
Thank you. There's a request from one of our participants for you to elaborate a little bit more on the IT infrastructure that's needed, especially in primary care practices that are not part of an integrated health system like Kaiser Permanente.
Yeah. Right. So there's a great interest, of course, in linking together primary care practices with regional hospitals and with the specialists, and I know that it's not a reality these days, but there's movement in that direction. I don't know, we don't have time to certainly get into a whole lot of detail on this, except to say that I would strongly encourage, I mean, I think everyone who's going to plan on being in primary care practice for more than a few years, it really has to bite the bullet and get an electronic record system. But the caution is to try to develop systems that talk to each other. So simply getting an electronic record system that works in your own practice is just, it may meet the needs of today, but it will not meet the needs of tomorrow. And so we need to be thinking about health information exchanges where you don't have a single system, but there needs to be at least the ability for systems to talk to each other.
Yeah, that's certainly, we get a lot of questions still about that, and certainly there are resource requirements on that level as well. There were a few other questions about how this would be, if this would be plausible in an environment that does not have an electronic medical record. They're still on a paper system, but I think that certainly everyone is going to be moving to electronic health information sharing on some level in the future. So I think that's the direction we need to focus on.
Yes.
There's one participant who asked what your thoughts were, your speculation as to why the skilled nursing facility was so impacted on your data collection related to the study.
Yeah, I can speculate, but again, I can't provide you with data on this. But I think just from talking to the nurses, we asked them, like, how were they able to reduce the use of skilled nursing facilities so much? And I think the answer is along these lines, that these are not long-term care, like nursing home residents. These are typical skilled nursing facility 21-day admissions following a hospital discharge. And the explanation that I think is probably most accurate is that because the guided care nurse would interact with the hospital discharge planner as the discharge plans were being made, the guided care nurse would often say to the discharge planner, you know, I've been to this person's home. I can describe to you, the family, what the physical layout is like, how they can get from, you know, home to rehab, the laboratory, pharmacy, and I can help facilitate the plan that you put together. And that, having that resource was probably reassuring enough to the hospital discharge planners that they were willing to send more people home directly from the hospital because they knew that there was someone there that was going to do the transitional care. Whereas the hospital discharge planner who has none of that knowledge would be probably prudent to say, I think we better send them to a skilled nursing facility so they get a little stronger and before they go home.
How about the cost out on all of this? Did you translate any of your findings into cost savings so that if a primary care practitioner was going to their insurer to say, look at this data and this would probably be the cost savings we could help you save?
Yeah, you know, we did that once in the first paper that we published. But the problem is you have to make a lot of assumptions about costs. You know, and depending on who's paying. For instance, if it's a managed care company paying a hospital, they'll often have preferential rates compared to what Medicare pays the hospital. There are different costs of the nurse and having the nurse, and the average cost, say, of a SNP admission or of an episode of home care is very different in different parts of the country. And so when we did this exercise in trying to turn the kinds of reductions in utilization that I showed you, we tried to convert that into dollar costs. We got a lot of concern that we were, you know, just making assumptions that wouldn't be valid in all parts of the country. And so we kind of backed away from that, and now our response to people who want to convert it into dollars is to say, well, take the reductions in utilization that we've reported, and it's assuming that you could reproduce that, you can pretty much make your own assumptions about what is a hospital admission worth in your area. So if there were a 15% reduction in hospitalizations, well, you turn that into dollars in your environment, and how much would it cost you to have a registered nurse in a practice in your area? So I think the answer really is that we provide enough information about utilization change and nurses that organizations can make pretty good estimates that will be more applicable to their individual circumstances.
Absolutely. Can you talk a little bit about some of the partnerships that were forged or potentially forged through this program? There was a question about the relationship between the nurse coordinators and discharge planners at the local hospital. When there weren't already those established connections like they have at Kaiser, were there some opportunities that were found where they could help the hospitals do a better job of sharing information?
Yeah, that's quite individual, but the nurses definitely established partnerships with several other entities, not only hospital discharge planners, but they all became familiar with the AAA, the Area Agency on Aging, in their region, and there's one in every region of the country that is a great resource for community services. So the nurses all got to know their local AAA representatives and learned how to use those services. And then depending on their patient load, they would become acquainted and develop partnerships with, say, the local Meals on Wheels or adult daycare centers or whatever. But yeah, just by their clinical practice, they came in contact with a number of different either providers or organizations and developed working relationships with them.
Great. Thank you so much. I guess with that, we'll conclude. Thanks again for your time. It was really informative and terrific.
Thank you all. Thanks very much.
The organizer has ended the session, and this call will be disconnected. Goodbye.